I understand from the notes that Sue Ladwig left for me and an email explaining what she covered, that she touched on the RAND health insurance experiment, HIE. There's some discussion of it in the textbook. She quoted some pages about that. Probably the best simple 3 or 4 page summary of the health insurance experiment is on the RAND website. So Catherine has found this and has put it on Blackboard. You can go to Blackboard for the course, and somewhere it'll be apparent that there is a link to the RAND health insurance experiment summary. It's a very nice summary. I think it's quite an accurate summary. My reading of it, my understanding of the health insurance experiment, highlights of it, findings of it, and it ends with a bibliography of key things to read if you wanted to get additional insights by some of the major investigators associated with the RAND study. The first 2 items listed on the last page of that posting, or this printed out version of it, are by Robert Brooke et al. Brooke was a physician who got his MD at Johns Hopkins and also studied with the man who was really the founding giant of the field of health services research in that day, and did in effect a PhD in health services research, one of the first. A man whose name was Kerr White, K-E-R-R White. He was an English-born, Canadian-raised investigator, and all that's really relevant in understanding how the field of health service research came to be. It's a very international comparative area of investigation. And it lists other important publications by other key people, Kathy Lohr et al., which really summarize the key findings of that. But the best and most comprehensive publication to emerge from the study actually was concluded in 1984, but publications started coming out before. Publications continued to come out. There's so much data and so much analysis to be done. The major synthetic monograph, the book that actually captures what the study was about, its design, its major findings, implications of it, was published by Joseph Newhouse, who was the principal investigator of the study, an economist who had been trained at Harvard, and then after his years with RAND went back to Harvard. He is now a distinguished professor at Harvard in several branches of Harvard University, the Kennedy School, and so on. The name of the book is interesting in itself. There's a kind of irony built into the book. It's called Free for All, ? Lessons from the RAND Health Experiment. And the irony of the title is that free for all, used in common speech, can mean a brawl, a street battle, a free-for-all. And in many ways, that image captures what our healthcare system is like. It's a free-for-all, with a lot of people really punching each other out to gain advantage and to take full advantage of the way the incentives are structured in the American healthcare system. And it captures that notion, but it also raises the question of, should we move to a system of universal health insurance, which wouldn't be free for all by any means, but would seem to be, in certain structures of it, at least free at the point of service. You would pay for it in taxes, you would pay for it in other ways, as they do in Great Britain. It really isn't free. There is no such thing, and all healthcare systems are costly, all healthcare systems are inflationary, and these are things that, of course, Newhouse, as a first-rate economist, was well aware of, but he wanted to raise some of the basic questions that motivated the study in the first place, which ironically began as a study of the possibility of moving to a national health insurance experiment in the early 70s, when that was a central question and a very strongly believed possibility in the American policy and political world. By the end of the study in '84, it was long since dead, and the findings of the study and their application were largely taken over by the for-profit HMO health provider industry, and that's an irony we'll get back to later. Started in the early years of the 70s, supported strongly by the Democratic Carter administration, but concluded during the Reagan administration with very different implications. In any case, it's a very, very substantial book and a very, very good read if you have the time to really dig into it. Sue left me some notes about what she covered, and I'll read to you part of what she said, and then I'll invite you to comment on it and to add any additional suggestions you have about how I might go back and revisit some of what was covered last Wednesday. So she writes, I ran through the notes, covered some of the RAND HIE material, and then from there we turned to a discussion that you provided in your notes for Cost and Access in the U.S. Part 1. That's what I labeled the lecture. And I somehow managed to get through it with about 4 minutes to spare, is what she says. I told the class that I would ask you to revisit the locomotive engine analogy of how the public sector shovels funds into the private sector. So that's the essence of her report. I am prepared to do that if you'd like me to, but I'm also prepared to review or to cover any other material that you might have some questions about or would like further discussion of from Wednesday. Does anyone have an issue you'd like me to revisit, open up? Do you want me to do the locomotive analogy? And as I would do it in my usual somewhat theatrical fashion. So, any questions first? Everything else clear? Okay, well, let me get back to my notes for that last part. It was on the fifth point. The fifth point, trying to explain the apparent anomaly, the discrepancy between the percentage of the overall health budget that comes from public funds provided by government, which is somewhere in the order of 50%, just a shade under 50%, whereas the number of people covered by those public funds is a shade over 30%, around 32%. That's an enormous discrepancy. So the question is, why would 50% of the budget come from public funds, but only cover 30% of the population? And there was a list of 5 possible explanations, mostly dealing with the questioning to common sense that says, oh, that's easy to explain. We know the answer to that one. Public programs are ineffective. They are inefficient. They are bloated bureaucracies. They are rife with corruption. Money is wasted. And so we can understand why you pour a lot of money in to get less output. That's the discrepancy between 50% of overall budget, only 30% population covered. And then following my notes, Sue went through other explanations, some of the key elements of which is that Medicare and Medicaid money goes to pay for other things, not just patient care, very important things like uncompensated care. Some of that money, a good part of it, comes from Medicare funding. Medicaid funding goes to cover patients who formerly were institutionalized and paid for out of the state budget in psychiatric institutions or developmental disability facilities. People born with profound developmental disabilities are often kept in institutions, and they are now largely funded through Medicaid funding. There's a very significant portion of it that goes as a form of what can be called middle-class welfare, where the elderly of middle-class family with middle-class values, with middle-class monies, actually get put on Medicaid budgets, while their family can, through legal maneuvering and special trust arrangements and so on, keep the money that grandma intended to give to Johnny to go to college and so on, if they've arranged it properly, while the public picks up the tab to pay for their long-term care in a nursing facility, which could cost as much as $15,000 a month. Think of what that would do to a family's resources. $15,000 a month, which is not paid for by the family, instead goes to whatever their perceived needs are and priorities by these various legal maneuvers, and the public picks up the funding. That's a very important part of the Medicaid budget for long-term care costs. But the fifth and most interesting in my mind of the explanations is that a large part of the money, except for that which is allocated directly to the Indian Health Service, and even some of that now goes to private vendors and private providers. through arrangements made often at the tribal level, at the local level, or the VA system, which may be moving more in the direction of privatization, or a few other things. The money does not go from the public purse to salaried or centrally budgeted hospitals or other facilities, but goes as payments into the private system. It's public money which is shoveled into the private system. And it is the private system which sets the rates. And there are, in very significant ways, prohibitions for the holder of the public funds, which would have considerable bargaining power if this were a real negotiation, to say, we don't like those rates, and we're going to negotiate them down. Because we have all these patients to pay for, we have all this money to give to you, and we want something in return. This is what a negotiation is about. That's not the way it happens in certain significant parts, especially of the Medicare budget, and there are reasons for that. So the net result is that, to a large extent, the private institution says, this is what you're going to pay up, or we don't take care of the people you want us to take care of. So how did this crazy situation come to be, where you tie behind the back both hands of the public provider and just say, give us money, shovel it over, we'll tell you how much, and we'll tell you when to deliver it, which is why a lot of this discrepancy is happening. It's very different from our expectation. There is a suggestion of what this might be about, but not really developed, by Shi and Singh on the bottom left on page 214. This is what Shi and Singh say on that page. Medicare for the elderly and certain disabled individuals, that is, some people who qualify for disabilities by the very stringent criteria of the Social Security system, can also get their health care paid for by Medicare. People with end-stage renal disease can get that provision by Medicare, some weird provisions, but mostly it's for the elderly, the retirement age population. Now, even though the government finances public insurance for the most part, health care services are obtained through the private sector, whereas in contrast, financing and delivery functions are largely integrated into the VA system as a contrasting use of public funds. So a strong Memorial Hospital, a strong health system, for example, just over there, will have Medicare patients mixed in with its private pay patients, with its patients paid for whose insurance is covered by Aetna or Excellus or whatever, all mixed together, all sort of sitting in seats next to one another in waiting rooms, seeing the same physicians, having advantage of the same facilities and services and so on, with different payers having negotiated rates. But the rates for the Medicare patients can't be negotiated to the degree even of the private patients, and not to the degree that the number of patients would suggest would be possible in a good negotiation. This system, as weird as it may seem at first, made sense when Medicare began in 1965. That's when the legislation was passed. We'll be talking soon about the history that got us to 1965 from the turn of the 20th century, and why in 1965 it seemed like a great triumph to get to the point where the U.S. Congress could pass by a substantial majority with considerable Republican support, not just Democratic support. There was bipartisanship in those days to a large extent. We have forgotten a lot about that. Maybe we'll see it back in healthcare now that the debacle of Trump care has gone belly up once again. Zombie apocalypse has returned and left again. You cannot kill the undead. And there is now a possibility, which had actually begun before this latest version of it, to have Democratic and Republican cooperation on trying to fix things which are clearly wrong with the Affordable Care Act, rather than to destroy it by the sabotage that the Trump administration is now doing through administrative means. But we'll get to that later. And to really fix it and make it work, rather than to kill it, either legislatively or by administrative subterfuge. In any case, back in 1965, when there was bipartisan cooperation, there was still considerable fear that though we have a very substantial legislative majority and clear national will to pass this program for the elderly. We have a very sad and sordid history in this country of very badly segregated institutions that first really began to become integrated only in the 1960s and only under the pressure of Medicare funding used as a carrot and stick to force some hospitals, not just in the South, in non-southern urban areas as well, to integrate. If you don't integrate, we're going to withhold this big bolus of federal money, so you better damned integrate. And then institutions tried in various ways, both legitimately and illegitimately, to follow the letter of the law, and then finally the spirit of the law when the authorities came down and said, "Oh, you didn't do it, you're faking," etc. All of this was still going on in the 60s. So the clear understanding was, if we create streams of money to pay for poor people, or at least some poor people, through Medicaid, and pay for elderly people who are very often going to be poor and sickly through Medicare, then it's quite possible that fancy institutions are going to create segregated facilities or segregated services, or we're going to put the money into institutions run by entities of government, metropolitan hospitals in cities like New York, or county hospitals as in a place like Rochester, or state hospitals, and that's where we're going to shunt all the poor people using this money, keeping them away from middle class and wealthy people who'll be going to the fancier institutions. That's not what we want. We want a quality program. And the best way to assure a quality program is to provide funding for Medicaid and Medicare patients to get their care alongside other patients in the major facilities of, let's say, Strong Memorial Hospital and its satellite clinics and services. So that means that we pay publicly funded patients to use private institutions, and because there was so much fear at the startup of Medicare and Medicaid, even though it was a considerable political and legislative victory, because there was so much bitter battling over this political process, that as soon as the money started flowing, hospitals and doctors would together conspire to sabotage the program. And the only way those, in retrospect, very short-sighted administrators thought they could guarantee the success of the program that had this big legislative support was to make it so remunerative, to make it so generous, to stuff the doctors and hospitals' mouths with gold so that they would comply. Make it so generous that they would want the money and would deliver the services, but that meant giving away a lot to keep the possible saboteurs quiet and to make sure that there was real collaboration rather than conspiracy and controversy and resistance. And that meant that the private system, at the get-go of the program, was allowed to set the rates. If the private system sets the rates, that means the public administrators of the system have a choice. We either, because we've inherited this crazy, stupid system from the 60s, now in the 2010s, we either have to keep up with the rates or risk having the patients whose services we want to pay for denied service, or be given skimpy service, or being given shoddy service rather than the robust quality service that we want to pay for. And so if they raise their rates, we have to raise our allocation. We have to keep up in order to keep our patients in the system. And so you need to do a gestalt shift. It's one of those gestalt shift things. It's not that public funding in inefficient and corruption-riddled programs is pushing up healthcare inflation, because so much of the budget, near 50%, is coming from public funds, and it's done in a very inefficient and corruption-riddled way, and so on. It's not that there's a push on inflation from the public programs, and therefore we have to cut it back and make our system more private. and have more market rather than more regulation or government oversight. No, 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 no. We need to have more private stuff. Oh, shit. Yeah. In fact, though, the reality is instead of it being push, 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 push from wasteful public allocations, it's pull, 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 pull from the private sector, which is acting in a greedy and manipulative way. So instead of pushing, what's really going on is sucking. The private system is sucking resources in. And so it is legitimate to say, literally as well as figuratively, that the U.S. healthcare system sucks. And it does, in this fundamental way. Yes?
Isn't it true that public insurance, so Medicare, Medicaid, pays substantially less per patient than any private insurance?
And you know what? Maybe they should. And maybe the private insurance has a lot of inflation and special dealing built into it. Have you ever done an analysis of what it really costs to take care of a patient? And in some cases that may be the case, in other cases it's not the case, but compared to what? And what are we really paying for when we pay different rates in the private system? We're paying for very substantial physician incomes and very substantial hospital budgets. But how are those budgets determined? I think we have to get to that issue. It is not based on a market consideration. We do not have a market in healthcare. What we have is a monopsony system in which a few institutions control the prices. Yes.
But the public, I mean, Medicare, Medicaid do pay substantially less per patient, and how can you argue that?
That may be true for Medicaid in certain instances. It's certainly not true for Medicare. And what is the source of your information?
I worked in a hospital.
You worked in a hospital. And you spoke with the budget offices of the hospital, or you spoke with physicians who were delivering service and they'd be grousing over costs? Administrators. And you saw their budget figures? Okay, well, we have to deal with those issues. And did you see why the administrators charge, for example, $18 for an aspirin that you can pay 13 cents for over-counter? Or why they charge $400 for a particular blood test that analysis indicates costs $24 to produce? We're going to get to an issue called the charge master, which is what administrators use to set prices, which is a shill game to negotiate with various entities that pay, private entities and public entities. And in many cases, the public entities are stricter and tougher about what they are willing to play in this game and pay in this game. Administrators are doing their job effectively if they're maximizing resources into the institution. But if they are maximizing resources into the institution on the basis of strange assumptions and shoddy ethics, they're doing their job, but is the country or is the locality getting its money's worth? And that's really the crucial question. So, back to, let's see, where was it? Okay, so the public monies are trying to keep up with very high expectations of payment, which are increasing regularly and rapidly. The rates are being set, the rates are being inflated, and Medicare and Medicaid, to keep their patients in the mainstream, to keep them in the same system, getting presumably the same quality care, has no choice but to keep up with the demands for reimbursement. And in many instances, the rules are set so that Medicare and Medicaid, especially Medicare, especially through the Part D drug program, has been specifically disallowed by federal legislation to use its bargaining power to negotiate rates for pharmaceuticals, for example, with the entities, even though this is a practice that private insurers are allowed to do. Aetna is allowed to negotiate its rates. Excellus is allowed to negotiate its rates. But under Medicare Part D, as it originally passed in 2003 under Republican administration, Medicare was not allowed to negotiate its pharmaceutical rates. That only began to change under the Affordable Care Act, under Obamacare, which is one of the reasons that it is anathema to so many Republicans, because it changed the rules that had been set back under George Bush in 2003. But we'll get to that. So I think we need to do a Galileo. We need to do a Gestalt switch. We need to interrogate common sense. And we have to see Medicaid and Medicare not as the drivers of inflation, but struggling desperately to keep up with the rates that are set and that they're expected to pay to get the services they want for their patients by the private institutions. Okay? Now, this is getting me to my locomotive and shoveling analogy. One way to think about this is to imagine the situation is this. We're in an old-fashioned steam locomotive, which is heading up a treacherous set of tracks. And in fact, maybe the locomotive engineer even knows that at the end of that treacherous stretch of tracks, there is a trestle down. And if the train, to make it even more dramatic, if the train continues on that track, it's going to go down and plunge to the destruction of the train and to the death of all the passengers who are riding on that train. But here are the rules. As the engineer, you are not allowed to touch the throttle. All you do is keep the train on the tracks. And even if you see a dangerous impediment, you cannot adjust the throttle, you cannot change it. And behind you, in the old-fashioned locomotive, there is someone called the fireman, who just has a big pile of coal, and he shovels the coal into the burning engine, shovels the coal into the engine, shovels the coal. The rules of this system are that you, fireman, shut up, shovel, shovel, shovel. You have nothing to do but shovel. You cannot stop or the train will stop. It must continue going. And you, engineer, even if you see danger ahead, you cannot control the throttle. Keep going right over the cliff, right down the down trestle and into your death. The government is in the position of the fireman and the train engineer. They are not allowed to touch the throttle. All they are allowed to do is keep on shoveling and keep the train on the tracks. You might think this sounds crazy. It is crazy, but it is our system. And it has only begun to change, at least for a major component of that, pharmaceutical costs, because of some political changes under the Affordable Care Act, which began to modify Part D of Medicare. So we have to go to Part D. Part D of Medicare was passed, as I've indicated, under the Bush administration. It was a mechanism for helping cover the increasing expense of pharmaceutical products. When Medicare began, drugs didn't cost that much. They weren't a significant percentage of the overall budget. Other things were much more worrisome, hospital costs and so on. But as medicine has evolved and changed from 1965 to the present, certainly to by about 2003, pharmaceutical costs became a much more significant part of the overall budget. How did that happen? Okay, why? How did it happen is a complex of many things, but why, when there was finally some political will to address pharmaceutical costs and to add payment for drugs which were not included in the original Medicare, those were out of pocket. When Part D was added to the other parts of Medicare, why was it created the way it was created? Well, there is very little explanation of all this in She and Sing, which is another, to me, disappointing part of their book. So they mention this briefly on the bottom right column of page 218 and continue discussing this on page 219. Part D, prescription drug coverage, was added to the existing Medicare program under the MMA, in terms of Medicare Modernization Act of 2003, and was fully implemented in January 2006. The prescription drug program requires payment of a monthly premium to Medicare, which is in addition to the premium for the other parts of Medicare that people might be paying for. Coverage is offered through two types: private plans approved by Medicare. They're either standalone drug prescription plans or they're part of what's so-called Medicare Advantage programs, which are essentially Medicare HMOs that provide some additional services in addition to the pharmaceutical program. Medicare Part D, now here's the key part, requires payment of a deductible, following which a basic level of coverage becomes available. After that, there is a coverage gap, or so-called donut hole, which requires the beneficiary to pay the full cost of drugs. Skip the parenthesis because that was added after there were modifications under the Affordable Care Act. To pay the full cost of drugs until a defined level of spending is reached. The gap is then followed by a catastrophic level of coverage, etc. And then they point out that effective in 2011 under the Affordable Care Act, Part D, drugs must be covered with a manufacturer's discount, blah, blah, blah. In other words, manufacturer's discount and modifications in the original Part D to make that donut hole. You get initial coverage, then there's a big hole in the middle when you pay all out of pocket, and only when it reaches a much higher level does another co-payment part kick in. It's a very complicated system, but the main thing is that there is no discount allowed. The discounts that were demanded of pharmaceutical companies through the system were only added as part of the Affordable Care Act under Obama, were definitely excluded during the initial political negotiations under the dominance of the Republican majority and President Bush very happy to sign it. Did the Democrats like this? No. Some Democrats hated it. Some Democrats were extraordinarily outspoken. There were also public interest groups that were politically not identified with any particular party, which got into the act and made analyses of these programs and the legislative proposals and tried to cut through the rhetoric and the baloney that surrounds lots of legislation to get to the essence of what was going on. The most effective groups were various PIRGs, which are public interest research groups. There are public interest research groups at the national level and at the state level. The basic public interest research group that was very effective in at least analyzing, if not persuading, various legislators how they should respond was the one founded in 1971 by Ralph Nader. And maybe you know that name as this pioneering, courageous consumer advocate who was an undergraduate at Princeton, did his law degree at Harvard, and so on, became a very, very effective consumer advocate and really created that whole consumer advocacy movement. And he also founded this public interest research group to do some investigations. This is what they said at the time about the various proposals. Let me quote. Congress, they wrote, should immediately rescind the provision in the Bush administration's Medicare law that prevents the federal government from negotiating with the drug industry on behalf of consumers. So written into the legislation that was part and parcel of the 2003 Medicare Part D were provisions that said that the federal government could not negotiate with drug companies because they had all these consumers, just as private entities were allowed to negotiate. They were prohibited from negotiating, so that in effect, the private pharmaceutical industry, Big Pharma with its big lobbying presence, would get a windfall profit by not having to negotiate down its prices but pay the full freight. It was a blatant use of lobbying power to produce legislation that many people, on the other side at least, the Democratic side, thought was horrific, that public interest groups thought was absolutely intolerable and unethical, but it passed and it had significant impact. The federal government should negotiate, PRIG said, lower drug prices on behalf of the 40 million Medicare beneficiaries. That's a big group of people. They have considerable negotiating power. But the Medicare Prescription Drug Improvement Modernization Act of 2003, signed into law by President Bush in December 2003, prohibits administrators of the program from entering into voluntary negotiations with drug companies to achieve fairer prices. It was prohibited. It was the legislation. It was legislation, in effect, written by the private pharmaceutical industry and endorsed by the Republican legislators and the president, who were very much influenced by them because of the lobbying connections. New York State, PRIG published additional analysis, and they asked certain basic questions. Where is bulk purchasing of prescription drugs already done? Elsewhere. In the VA system, for the years, the Department of the Veterans Administration has been using its buying power to negotiate lower drug prices. It's used by private companies. Some of America's largest private employers have banded together in buying clubs to bargain directly with drug manufacturers to get lower drug prices. It's allowed at the state level for Medicaid in many states, but it wasn't allowed for Medicare. Representative Henry Waxman, an outspoken liberal Democrat, charged in July 2008 that, quote, in effect, Medicare Part D has given the major drug companies a taxpayers funded windfall worth billions and billions of dollars. That only changed in the Obama administration with modifications to that legislation. So instead, we have this great boondoggle. Now, certain congressmen, then House of Representatives Congressman Bernie Sanders from Vermont, and Senator Schumer from New York, and other representatives of states that were close to the Canadian border, in an act of defiance and to help many of their constituents, organized bus trips, loaded their citizens, Vermonters, New Yorkers, onto buses, crossed over the Canadian border, where the very same medications, the very same labels, were sold for much cheaper prices, because in the Canadian system, the Canadian version of Medicare has considerable purchasing power, which it uses to negotiate down drug prices. And so the very same thing that you would pay $40 for in the United States, $100 for in the United States, you can get for a third or a quarter of the cost in a pharmacy in Toronto or Montreal or wherever the bus wound up. And so they did this as a public defiance, as a demonstration of the craziness of the system. The rules for Medicare Part D were also very strangely written. They were very confusing. They were really, it took them 3 years to sort out. Many people were actually prevented from getting their medication even when they were following what they thought were the rules, because the complexity of it was so great. And the real insights were captured by political cartoonists. And so here I want to rely on the handout and political cartoonists who were able to specify clearly what was going on. There's Grandma and Grandpa looking at the new Medicare drug benefit enrollment form, which more or less read like this. This is probably more coherent than many of the forms. Take the age and multiply by MC times the square root of 2 divided by 1.0092 plus the milligram dosage of your green-colored versus your purple-colored pills minus the middle initial of the prescribing physician's niece etc., etc., etc. It's made to sound absurd, but many of the regulations struck perfectly rational people, not only the elderly, but those who tried to navigate and help them, as absolutely absurd. As I said, it took 3 years to sort this mess out, and many people were deprived of the medication. There were class action lawsuits against the government for literally killing people because they weren't getting the medication. But Grandma and Grandpa can understand the bottom line in the big letters. Congratulations, you've enriched the drug industry. It was a boondoggle, it was a giveaway, it was rigged by the lobbying interest in collusion with the Republican leaders who pushed this through and then signed it. On the bottom you see another cartoon of what this health reform is really all about. Here's your special wallet for your new HMO card. You can put in your ID, the government drug pharmacy and doctor's cards, and then with all that other stuff, you have this tiny little change purse here where you can put in all the coins that you save by using this program. Oh, wow. Whoopee, whoopee. And then on the other side, I think, are some other clever cartoonist comments. We don't need a special card to get a good discount on prescription drugs. We need that other card called my driver's license. Head for Canada, over the border. If you can't get on Bernie's or Chuck's bus, drive yourself up there and do that. It's just the same medication. And for some reason, tickles my funny bone. I don't know why. The one on the bottom is a before and after, then and now, of two folks who in an earlier hippie stage said, I'm going to Canada for cheap drugs, and now, I'm their workers. I'm going to Canada to get cheap drugs too, different ones. Anyway, I find that amusing and quite an insightful comment. Now, I think you have to put all these things into perspective. And when you look at this disproportion between the percentage of money from public sources and the number of patients covered, you cannot separate it out from these various important factors that explain why that happens. And please don't jump to the conclusion that it's because public programs, federal programs, are inefficient, bloated, corruption-ridden, and that's why the costs are so out of proportion. It's a different story entirely when you look closely. So I think we need to turn for about 2 minutes now, and then obviously more time on Wednesday, to the next major topic, which is why we have such an excessive per capita expenditure for health care in the United States. It's expensive in almost every country. It's inflationary in almost every country. And you can get a good sense of that by looking at Shi and Singh, pages 468 and 469, most graphically, literally, on page 469. There you have, across the page, a series of paired bars, a lighter blue bar and a darker blue bar. The lighter blue bar is what percentage of healthcare spending as a percentage of the GDP, what it was in various countries in 1985. And the darker blue bar is what that percentage was in 2009. And we can see in every country, the darker blue bar is larger, in some cases considerably larger, than the lighter blue bar. In every case, there has been inflation. This is part of the dynamics of healthcare systems as they are organized in our modern age. But in every country, though the increase was quite substantial in some cases, in the UK from 5.9 to 9.8, let's say in Australia from 7.5 to 8.8, etc., there was no country in which the starting point was higher, 10.1% of the GDP in 1985, and the end point when this data was collected, higher, than the US at 17.4. So though this is a phenomenon of modern healthcare systems, of high cost and inflationary tendencies, that high cost is higher than anywhere else in the United States and seems to be going up faster than anywhere else in the world in the United States. And this graphic really captures it very, very effectively. The question then becomes, which we'll have to wait till next time to turn to, is why? Best pages to read are Shi and Singh, pages 471 to 476. And to pay attention especially to the summary list of factors on page 472, top left. We're going to return to this discussion and apply it to the U.S. comparatively. Which of these explanations that have been offered by astute observers and students of healthcare systems really make most sense? They all have some relevance, they all have some truth to them, but which make most sense for explaining why the United States is the outlier, why it began at a higher pace and grew at a faster rate. That's something that Shi and Singh may not, as adequately as we would like, explain fully. So we'll get to that next time.